Dr. Manish Wankhade, sir. Wankhade will be presenting on case of intraoperative fluid misdirection syndrome.
So, good afternoon, everyone. Myself, Dr. Manish Wankhade, and today I will be discussing a simple case how it turned out to be a complicated. A normal for 63-year-old female with normal age-rated cataract with grade 2 to 3 nuclear sclerosis was planned for under cataract surgery to undergo the cataract surgery under peribulbar anesthesia, routine phacoemulsification. My phaco settings were normal as we do for this type of normal cases. After making the initial incisions and rexis, I planned for a cataract removal, routine phacoemulsification under direct chop. Everything went well. There was nothing suspicious while operating this case. As the case progressed, I started with my bimanual irrigation aspiration to remove the cortex. Initial first half of the cortex was removed very happily, and we were planning for a lens to be brought in the AC OT, and then problem started. The anterior chamber starts shallowing so much so that any maneuvering felt risky. The PC start bulging upward, and introduction of any instrument was most probably like it will be touched the posterior capsule, and then sometimes the complication happens when we least expect them, and this was the same case. I started planning at back of my mind to what to do, so I initially injected the viscoelastics from main port and side port, but the PC was not ready to get settled and go down, so I removed the speculum. I injected more viscoelastic, high density viscoelastics from main port to get more space inside the AC, so I can remove the remaining of the cortex and can implant the IOL. The speculum is also changed. So after thinking a lot, then I come to the conclusion that I will need a vitreous tab. So I took a pars plana vitreous tab with a 26 gauge needle, and as soon as the tab is done, and I didn't aspirated anything, it is just a tab and a small drop of the fluid came out, and the PC got settled, and I can happily inject the IOL, settle it, and the part of the cortex was remaining in 1 to 2 clock hour was then removed. These kind of cases generally happen when there are the weak zonules or botal height is 2, or for while operating the machines like Alcon, where the intraoperative IOP can be settled. When we set a high IOP, there is chances of intraoperative fluid misdirection syndrome. I will like to share one such more example. Similarly, when I was planning to operate on a cataract, the dye went inside the vitreous cavity, and the whole vitreous turned out to be blue. And after removing the cortex, and the vitreous remained blue for nearly 2 to 3 days. So it was a blue vitreous cataract. Thank you. Thank you, sir.
So, which are the eyes which are predisposed to intraoperative fluid misdirection syndrome?
Sir, I can't correct the question, but
Which eyes are predisposed to?
Yes, sir.
Is there any predisposition that these are more prone to
sir,
develop?
until now this case happened to me. After that I researched and studied a lot, and many seniors give me advice that the cases where we have done a preoperative vitrectomy, eyes which underwent a vitrectomy, eyes which are high myopia, then high hypermetropia eyes where we are operating under high anterior chamber pressure or operative IOP, the eyes are more prone for this. And rather than other eyes like post-traumatic cataracts, the eyes which have suffered and some kind of trauma with a zonulopathy are generally prone for the fluid misdirection syndromes.
Yes, I think not myopic but small eyes, with weak zonules, pseudo exfoliation, eyes with shallow anterior chamber, they are more predisposed to aqueous misdirection syndrome. And another thing is sometimes what happens is chamber is shallow and you try to force trypan through, like it happened in your case, and it goes through the zonules and the whole vitreous becomes blue, the surgery becomes difficult, and the eye is very hard. Those are cases sometimes which becomes very difficult. Better is to just wait, like I think you did right thing by tapping the vitreous, wait, give mannitol, and let things settle down, and then on, instead of just trying to hurry up.
Thank you, sir.